Well, thank you very much, and welcome to this session on writing technical sections and the health economics. So I'm going to spend the next 45 minutes talking to you about how to work with a health economist. And so, as Izzy said, and in line with Natalia's session, the aim is not to teach you how to become a health economist, but how to work with a health economist and to make your application as strong as possible in that regard, if you're including that element. It might be useful just to provide a bit of background in terms of what health economics is all about and what we do. So there's a wide range of things we get involved in, but health economists are interested in costs and outcomes. So we explore resource use within healthcare. We look at costs within healthcare from different perspectives. So who's bearing the costs? Is it the NHS in the UK? Is it the health service? Is it social care? Is it patients? Or is it all costs as borne to society? We look at the effects of interventions on health-related quality of life using measures such as the Euroqual EQ5D or the short form 6D. Or ICECAP, which is a measure of capability well-being. We look at the wider effects of interventions on lost productivity or education for children. A lot of what we do is conduct economic evaluations, such as cost-effectiveness analyses. These can be based on clinical trials or based on models. And I'll say a little bit more about those in the next few slides. We might conduct budget impact analyses. And finally, we might collect information on preferences and conduct discrete choice experiments and look at willingness to pay. And this is by no means an exhaustive list, but it gives you a few ideas of the types of things that health economists work on. So here's a few example publications from the Health Economics Research Centre, where I'm based at the University of Oxford. And again, you can see there's many ways that health economists might be contributing to research work. We've got a cost effectiveness study alongside a trial. We've got quality adjusted survival and cost effectiveness here. Again, looking at health related quality of life. We've got literature reviews and meta-analyses of cost effectiveness studies, looking at the challenges of conducting these types of evaluations, and a study looking at both the affordability, the budget impact, and the cost effectiveness of new treatments. Lots of different things. So I just described what an economic evaluation is. And if any of you have worked with a health economist before, there's a good chance that was on an economic evaluation. And if you end up working with a health economist in the future, it may well be this type of work that's included in your grant application. So the NHS, let me explain what economics is all about. So economics is all about, we're starting from the dismal place that we can't have everything that we want. So we have to make choices about how we allocate things. And even in the NHS, where we aim to secure the provision of comprehensive, high quality care for all those who need it, we can't do absolutely everything. We've got a limited budget, and so we still have to make trade-offs about what we're going to offer and to whom. And we have to make choices. An economic evaluation is a way of making those choices in a sort of systematic and explicit and transparent way. So the aim of economic evaluation is to maximize the health gain we can get with our available resources. So we want to compare costs and outcomes of new and existing interventions. And that data can come from a clinical trial or from a modelling study. And the sort of textbook definition of an economic evaluation is that it's the comparative analysis of alternative courses of action in terms of both their costs and their consequences. So we talk about costs and consequences, costs and outcomes, costs and benefits, costs and effects. We use lots of different words, but essentially we're interested in those two things. And there's there's lots of key elements, but certainly 3 key features of an economic evaluation and things we'd be talking to you about is the comparator. So we've got our new intervention, but what are we comparing to? We're always comparing to something else, which is likely to be the current standard and the current drug that's being used or current technique. We're interested in the perspective. So whose costs are we going to capture? So NICE recommends taking an NHS and personal social services perspective, but there may be cases where there's a lot of family support and informal care or time off work, and we want to take a wider societal perspective and capture all the costs regardless of who bears them. And finally, another important feature is the time horizon. How far into the future are we going to capture our costs and outcomes? And in some instances, if we've got an antibiotic for a short-lived infection with no long-term consequences, we don't need a very long time horizon. But if our intervention is going to affect mortality or have effects way into the future, then we need to capture all those things, the costs and outcomes way into the future as well. So there's some of the key features to think about and that we would be talking to you about for your study. So as I say, over the next few slides, I want to think about how you can work with your health economist to make your application as strong as possible. So just as Natalia was saying, when do we want you to contact us? The earlier, the better. If we can be involved right at the start, we can think about the most appropriate methods for collecting data on costs and outcomes or resource use and outcomes, and we can embed health economics aspects fully into the project. And we may have different ideas about how to collect the data, and then it's a discussion about what the best way forward for the study as a whole. We also need to cost our time appropriately. We may need to test out our methods, likely want to test out our methods of data collection and make sure they're feasible. If you have difficulty finding a health economist, do get in touch with the RSS. There are health economists all over the UK, although can be in short supply, but there's different expertise in different places, and we may be able to point you in the direction of a group that might be most suitable to help you, or we may be able to help you ourselves, but certainly try and help you, point you in the direction of a useful contact. So how do you work together? We'll cover a lot of these things in more detail as we go through the rest of the presentation, but I guess these are some of the overarching things that we want to do to achieve a good outcome and prepare a high quality grant application. So we want to ensure that the economic question is stated clearly in the objectives. And we want to ensure that the question and the approach is justified in terms of what we'll be undertaking and delivered, just as you want to do with every aspect of the methods for your application. We need to ensure that the proposed data collection and analysis is reasonable and feasible within the timeframe and budget of the grant. And we also need to think about the burden of data collection, particularly on patients, but also on the time available for research nurses, and make sure that it all looks practical. We want to adhere to best practice guidelines and agree key milestones and deliverables so that you and us, we're working together and we're all on the same page. It's very much a collaborative effort. And the first thing we'll do is ask you lots of questions. So I'm going to use the same case study example as Natalia. So this HTA call, Health Technology Assessment Call Programme call for applications to evaluate the clinical and cost effectiveness of physical exercise for treating depression in adolescents. So you may recall this was the plan for a 3-arm randomized controlled trial. And we're going to assume that you're designing the economic evaluation alongside this. So I'll use this as a case study and example, but a lot of the points will be transferable to other types of health economics study. So we're going to build up what the health economics sections of our grant application might look like for this. But just like Natalia, the first thing I'm going to do is ask you lots of questions. So you've got the clinical expertise that we need to, I need clinical expertise on a need to know basis. I need to understand enough to help me design and conduct the economic evaluation. So, and you're also probably going to be much more familiar with the clinical and scientific literature of your topic than we are, because we tend to work in a number of different areas. So I'm going to be asking you about exactly what you're planning to do, the design of your trial, but I'm also going to be asking you about the patient pathway, because I'm really interested in what happens to the patients, so I can think about where the key elements of resource use are and where the key cost drivers are that we're going to want to be capturing in detail. And I'm also interested in the outcome, quality of life or whatever our outcome may be, but thinking about when that's likely to be a step change for patients. So if patients have surgery, there's likely to be a dip in quality of life. What's your expectations around recovery? And are you expecting one arm of your trial, say, patients in one arm of your trial, say, to recover more quickly than the other arm? And therefore, we want to make sure that we're capturing our outcomes at relevant time points, so that we're capturing things far enough into the future to capture all the impacts of the intervention, or we're considering some modelling to a longer time horizon. But to make sure that we're capturing the important changes for patients and also what might differ between our groups. So you're not going to get any answers to start with. It's going to be a lot of questions about what happens to patients and how this is all going to work, but that's going to help us design an appropriate study. Think about the different sections of your grant application. First section we come to is the plain English summary. So you want to explain in lay language the health economics aspects of the proposal. If it's a cost effectiveness study, you're likely to talk about value for money. That's quite an understandable way of thinking about what we mean by cost effectiveness. If it's a budget impact analysis, we might talk about the affordability of a new intervention. A budget impact looks at how many patients are going to be, if we're looking to introduce a new intervention, how many patients would be eligible for that and what would be the impact on our whole budgets? So can we afford to introduce a new intervention? So for the case study, we could have an overall aim for the economic side of things that we can write in lay language and say, the aim of this research is to find out whether exercise is an effective treatment for young people with depression, and then the economics bit, and whether it is good value for money for the NHS. And there may not be room for much more than that in your economics bit in the plain English summary. A couple of common errors, both within the plain English summary and elsewhere in the application. People often get hung up on thinking about an intervention needs to be cost saving to be good. And that's not true. An intervention may add costs, but it may hopefully also adds benefits. And if it does, then an intervention can represent good value for money. It can be cost effective without being cost saving. And of course, particularly if you're adding a new intervention, depending on what your comparator is, but if you've got a new intervention that's more expensive than your comparator, or your comparator is do nothing, then the first thing you're doing is adding costs. So making sweeping statements without any evidence to back it up that, oh yes, this is likely to be cost saving, is a bit of a leap of faith. So be wary of doing that unless you've got a very strong rationale for that. And we talk about costs and benefits, costs and outcomes. And if you start talking about cost savings as a benefit, clearly in everyday language, it is a benefit, but it just starts to muddy the water between the two sides of the coin that we're invested in, costs and benefits, costs and outcomes. So I think it's clearer and easier for people if you don't describe cost savings as a benefit. Section, and here we need to explain why the research is needed from a health economics point of view. So we're going to want to give some numbers about the burden of disease and the costs to the NHS or society. And indeed, you're going to want numbers about the burden of disease for your sort of clinical rationale for the study, but also is there any evidence about the costs to the NHS and the burden there? And then you're going to want to include information about any existing evidence in the area in the same way that you will do for your clinical aspects. Is there relevant research that's already been done around the costs or quality of life or cost effectiveness that you need to include so that the readers know kind of where the evidence base is up to? So the sorts of things you might want to include for the case study: what is the burden of depression in adolescents? What are the annual costs associated with depression in this group? Is there evidence around the quality of life impact of depression? And how cost effective are current treatment options? And some of the common errors: there might not be a health economics case presented, so then it makes it look like the health economics isn't very important. Or there might be evidence cited, but it's not for the same population, the same patient group that you're going to be looking at, so it's not really relevant. The next section that's going to require some health economics input is the aims and objective. And just skipping to the bottom of the page here, if there's no aim or objective related to the economics component, again, it suggests it's not important. So you need to be very consistent throughout the different sections of your application. And you know, if you've got an element of work that needs to be part of your objectives, needs to be in your methods, needs to be in your analysis section, it needs to be consistent throughout the application. And of course, you know, not everything can be the primary objective, but you can have a number of different objectives or secondary objectives, and it could well be one of those. So for the case study, for example, your aim or objective for the economics section could be to estimate the cost effectiveness of high and low intensity exercise programs compared to an active control for treating depression in adolescents. Our main section, economics section in your application, is going to be in the methods and analysis in your main research plan. So an important aspect of that will be what data will be collected, and you'll need to justify why you're collecting that data. So for economics, we're likely to want information on resource use and costs, and then also on outcomes. So capturing whatever the relevant resource use is for your population of interest and intervention under study. So it might be healthcare resource use, social care, it might be time off work, if there's a strong impact on that. It might be use of informal care, so friends and relatives helping people, looking after them. And then for every item of resource use, we're going to want a unit cost. So for example, if we capture the number of bed days in hospital, we need a cost per bed day in hospital, and we multiply those two things together to generate our costs when we do our analysis. And we also want information on health outcomes and quality of life. And we need to say how we're going to collect this. So is this going to be on bespoke data collection forms designed for the study, so self-reported by patients, for example, or collected by research nurses? Are we going to use developed questionnaires and instruments? So there's lots of outcome measures there that have been designed and validated. Is that what we're going to use? Are we going to interview people? Are we going to use routine data sources? So hospital systems, disease registries, national data such as hospital episode statistics, or primary care data from things like the Clinical Practice Research Data Link. And in all of this, we need to think about minimising patient burden and talking to our PPI groups about what's reasonable, and thinking about when the data will be collected. What are the important time points? So lots of things to think. So in terms of the case study, the sorts of things we're thinking about is, firstly, on the outcome side, we're going to want to collect data on health-related quality of life, and NICE recommends that we do that using the Euroqual EQ5D. So we're going to collect that at baseline and each of the follow-up visits, and then we're going to convert that into utilities or scores using established methods and UK population valuations. We may also want to consider other outcome measures disease or symptom specific outcomes. And there's likely to be one or more of these that's planned as part of the statistical analyses. I think Natalia mentioned a depressive symptom summary. So we might want to look at that as a secondary outcome measure for the economic side of things. And then we want information on resource use. So healthcare resource use will clearly be important, the intervention costs, other healthcare resource use, and then wider costs such as time off work potentially, if that's an impact, although this is an adolescent group, so perhaps time off education, carer burden, so parents looking after them, and we're going to want to capture this at each of the follow-up time points. So they're the sorts of things we'd be talking to you about, how important are all these different aspects? Should we be capturing them? Because there's this trade-off between, asking for 100 different things and the burden on patients and what's the most important thing to capture. So we're often the ones wanting lots and lots of data, and then we've got to rationalize that and make sure we're capturing the most important things, but we're not putting too much burden on our participants. It's important to say that everything we do is going to adhere to best practice guidelines. So mention that in your application. And again, this needs to be specific to the context in which you're working. The case study is a NIHR Health Technology Assessment Programme funding. So that's a UK perspective. We're going to be following NICE guidance along with the funder. And we also want to, and there's some references here to various aspects of NICE guidance, but we also want to follow other more international guidelines like the CHEERS guidelines, which are sort of international standards for reporting economic evaluation. So we want to follow those as well. And clearly not following the guidelines and not doing what countries expect for their jurisdiction is going to be a bit of a red flag for reviewers. So in terms of the actual methods and analysis, there's lots of features we need to cover. So when will the analysis be undertaken? Is it all at the will there be any interim analysis? And exactly what will be done. So you want to state your choice of perspective and time horizon. So I mentioned there key features of the evaluation. There's likely to be missing data. How are you going to handle that? Where are you going to get your unit costs from? If you do look at a longer time horizon beyond a year, then reviewers would expect to see that you're planning to discount your future costs and benefits. And where are you getting your rates from? Again, you want to be following good practice guidelines for the country that you're working in. How are you going to report your costs and outcomes? You're going to want to give details of that, and how you're going to want to consider uncertainty. Whether you're going to do any extrapolation. So I mentioned before, it may be that a within trial analysis might not be long enough to capture all the differences that the intervention brings to the group. So you may want to extrapolate your trial results to a longer time horizon. And then how will the analyses be done? What software will you use? So again, following sort of guidelines in this country, we're likely to undertake this from an NHS and personal social services perspective. The call requests a minimum of 1 year follow-up, but it does also say consider building in provision for longer term follow-up. So depending on what the kind of group decision is about what you would do about that, that might be, you might build in provision for that, but it might not be part of your analyses for this grant. It may be that you apply for money to do some longer term work, some further work afterwards. So you'll need to agree amongst the team kind of what the plan is for that. Multiple imputation is a common way of handling missing data within economic evaluations. So you want to say how you're going to deal with that. I mentioned before, if you're going to include longer term costs beyond a year, you're going to want to discount them. Again, the standard rate is 3.5% for the UK. And then you also want to think about, so up to now we've been talking about our base case analysis, which is clearly very important, but then you also want to think about, are there any additional analyses you want to do? Are there subgroups of patients, so certain types of patients with particular comorbidities or particular characteristics that you also want to look at in subgroup analyses. And these may well be the same as are planned by the statistician for the clinical analyses. Sometimes it makes sense to do the same, sometimes they're not always applicable to the health economics aspects. You're going to want to undertake some sensitivity analyses to look at how robust your conclusions are to uncertainty, but are there any particular aspects that you want to look at? Is there particular uncertainty around adherence or uptake, in which case you might plan some one-way sensitivity analyses around those aspects. And again, all this wants to be done following guidelines. So this all builds to here might be an example section, methods and analysis section for our grant application. So this really combines all that we've just said. We've got a first paragraph sort of about our methods and data collection and how we're going to go about all of this, and a second paragraph more about the analysis and how we're going to present the results. So our first sentence tells us it's a within trial analysis. So with the 1-year follow-up of the trial, it details the perspective and the time horizon. So we're going to conduct a within trial analysis, which will estimate the cost effectiveness of high and low intensity exercise programs compared to an active control, an educational package from an NHS and personal social services perspective from randomization to 1 year. So we've got our within trial analysis, our comparators, the perspective and the time horizon, all given in one sentence. And then we go on to talk about the primary outcome for the economic evaluation and what we're going to measure and at what time points. So the primary outcome is quality adjusted life years, estimated using the Euroqual EQ5D, collected at 6 and 12 months. And then we talk about how we're going to capture our resource use and at what time points. So resource use data collection will be integrated into the trial case report forms for the exercise programs and then collected at each follow-up from participants. And we say that we're going to follow guidelines. Best practice guidelines will be followed. And then moving on to the analysis. So we talk about how we analyse our costs. So we say where we're going to get our unit costs from, very broadly. Unit costs will be derived from nationally published sources and attached to resource use. And then in that way, we can generate our total costs per participant. We say how we're going to value outcomes. So responses to the EQ5D will be assigned valuations according to NICE guidelines at the time of analysis and combined with data on survival to calculate our QALYs per participant. We say how missing data will be handled. Missing data will be handled using multiple imputation methods. And then we say how we're going to present the results. So we're going to see our average costs and QALYs in each group to calculate what's known as the incremental cost effectiveness ratio, which is the extra cost to get an additional QALY gained for using one of the exercise programs compared to the control. We're going to conduct our analyses in Stata, so that's the stats package we're using. And we're also going to present our results in terms of a cost effectiveness acceptability curve. And this represents, in a diagram, the likelihood that each of the exercise programs is cost effective for different amounts that we're prepared to pay extra QALY. And this can help decision makers assess whether something's value for money, whether the exercise intervention is value for money. So we've packed quite a lot into these 2 paragraphs. And I think some questions came up this morning about, how do you write concisely and get everything in within the word count? Well, you see, for example, in the first sentence, we packed in quite a lot of things into that one sentence. So you do have to write quite concisely so that you get everything in. But and there may be other things we wanted to add here. So if If we thought mortality was going to differ between these two arms, then we might want to do some extrapolation to a longer time horizon. I've just focused on the within trial analysis here. If there were particular subgroups that we wanted to flag at this stage, we might put that in, possibly sensitivity analyses as well, but I think we've usually run out of space by at that point to put that in here. Another aspect, of course, of the grant application is the budget. And most health economists in academia don't have tenure, they're project funded, so we need to fully cover our costs. And we need enough time in which to do the work properly. So for example, if I was conducting a 5-year Wellcome Trust programme grant, which included a fairly significant economic evaluation, I might typically include my salary at 10% whole-time equivalent for the duration of the trial, so the duration of the study, so for the 60 months, and then a junior researcher to work alongside me, perhaps for 50% of their time for 2 years. I might incorporate some money for a conference. So here, for example, one national conference, one international conference. Include any training costs, particularly for the junior researcher. Any other costs associated with the design of the study, which might involve data collection costs or trips, or whatever is needed. Any software you need, and other costs including travel to project meetings or further data collection, etc. So it can add up, is likely to add up to a sizable amount for all this work to be done properly. And we also want to think about how we're going to maximise the impact of our research and our findings. So dissemination is important. I think historically, health economics results were quite often combined with clinical results in the same paper. But given the reporting requirements for both aspects have probably increased in rigour, we often run out of space for that and quite often report our results as a separate paper to the main clinical analyses. So you may want to think about that, particularly if your grant will pay for open access fees and publication costs, then you want to make sure that's included in the grant application. If that's appropriate, although there is a bit of a move away for funders to paying for that, and that's being paid in other ways. Final comments. If you'd like to know more about health economics, there are Introduction to Health Economic Evaluation courses run both by Southampton and Oxford, and other courses at Oxford, and indeed similar courses at many institutions across the country. So do have a look. And it may be helpful to include something like that in your grant application, if it's a fellowship, for example, to give you a bit more understanding of what this is all about. So my key take-home messages are, don't neglect health economics in your application. We can make a variety of contributions to your application. And it may well help to make your application look like a well-rounded package, incorporating different elements. Do contact us as early as possible to maximise these benefits, and get in touch with RSS if you're having trouble finding somebody. And be prepared to work very collaboratively with your health economist, and indeed all of your team, to fully integrate all the other elements into the application. And actually, I quite enjoy some of the discussions I have with clinicians and statisticians when you get all the different points of view around the table, to really thrash out the ideas about what we can do with a project. And I think you get a lot further that way by all talking together, probably rather than just doing things in silos. So it is very much a team effort. We can't do it without you, and you probably don't want to be doing health economics without us.